So hello everyone. This is the third session on adenomyosis in the blast series. I welcome all of you for this session. So I congratulate Dr. Aarti and Dr. Jay to continue this session, that to adenomyosis, which is quite interesting and which was requested by many. Also, we should appreciate Dr. Jay and Dr. Aarti for being here after a long day's work. And Dr. Jay, as you all know, I think he has been traveling quite a lot in the past 5 days. He was in Agra doing surgeries on Sunday, and yesterday he was here in Bangalore with us. Almost we finished 16 supramajor surgeries in just 24 hours. And after that, again, he went back, did quite a long list in Mumbai from today morning. And as committed, both of them are here with us to give us the very awaited session on adenomyosis and infertility. So I welcome all of you for this session. I thank both Dr. Jay and Dr. Aarti once again for having this session. Yes, Dr. You can take over.
Yep. Thanks, Shilpa, for that introduction. And I'll just share my screen. Can you see the screen? Shilpa, Jay?
Yeah, clear.
Super. So welcome everyone once again to the third session. And we are continuing our discussions on adenomyosis. And the last session we had discussed the platter of options available in the management of adenomyosis in women who have completed their family. And Jay, you gave us wonderful practical insights, and we'll jumpstart today's session on subfertility, and we're going to be only discussing this one case today. Jay, I know you had a hard day. We'll keep it short and sweet. And Jay and Shilpa and myself decided that we'll have it this way, that all the questions asked to Jay are going to be very impromptu, and he has no idea about what case I'm presenting to him. So this way we can get the most spontaneous, natural answers from him and more practical take-homes. So this was a woman who came to us, a 33-year-old with 10 years of primary subfertility. She has symptoms of dysmenorrhea since the last 7 years, and it gets relieved with painkillers. She also has a male factor subfertility, oligoasthenoteratozoospermia, normal ovarian reserve and AMH of 3. She's had 2 ICSI cycles, 3 frozen embryo transfer cycles, and all the previous 3 frozen embryo transfer cycles were day 5 double embryo transfer of good quality blastocysts, and all the results of the 3 transfers were negative. She has just 1 last set in the freeze, and that is also a set of good day 5 blastocyst embryos. Her previous 3 FET cycles were HRT cycles with the regular long GnRH agonist downregulation. So this is what we have, Jay. She's failed several cycles, and this is the ultrasound picture of hers. So you can see here the uterine length is around 9.5 centimeters. There is clear-cut posterior wall adenomyosis. The posterior wall is around 5.5 centimeters in thickness, with again the typical adenomyotic ecotexture. The anterior wall thickness is around 1.8 centimeters. So this is what we have when the patient has come to us for her ultrasound. So Jay, this is my platter of questions to you.
Yeah.
What are your personal options, and what is your take on all these options for endometrial preparation for a frozen embryo transfer cycle planning for a patient with this sort of adenomyosis?
So I think one thing is very important. If we minutely observe the ultrasound which you have presented, the lady has a very good triple line. Okay. And even along the posterior myometrium or posterior endomyometrial junction, the junctional zone is very well preserved. So that is one very great thing as far as adenomyosis and fertility is concerned. I think that should be driven home as an important take-home point. The minute you see that you have a triple line in adenomyosis with an excellent or probably the least distortion of the junctional zone, okay, you should be a very happy person, okay, because these are the patients who will get decent implantation. So I will not say very good implantation, because the minute you have adenomyosis, automatically the success rates, let's say you are promising somebody a success rate of 35 or let's say 40%. Okay. Now, if you add adenomyosis inside this, irrespective of all other factors, okay, the success rate will drop down by 10%. Standard. I mean, 10% drop in success rates as a practical standard should be advised. But when you see this, a good triple line, okay, one has to be a very happy person. So that is just one important comment which I wanted to give on the ultrasound. Second, I am really amazed that this pain is going to come down just with painkillers. Okay, considering the size of the adenomyosis which you have presented, it is, 1 in 1,000 case where a patient is going to have pain relief. But nonetheless, we've tried 3 cycles, as you mentioned, with GnRH agonist preparations, and the normal understanding about a GnRH agonist is that, once down regulation occurs, this down regulation is going to be a little prolonged down regulation. So if you are giving a depot of 3.75, you can expect down regulation for around 25 to 35 days. Okay. And if you are giving the 11.75, you can expect it to go on from approximately 80 to 100 days. Okay. That is the average which you are supposed to keep in your mind. You can use either one of them. But I think a very practical tip to use a depot preparation is when the endomyometrial junction is normal. Okay. Remember, any medical line of management, okay, any line of medical management will work the best when you have a good endomyometrial junction and the size of the uterus is less than 10 centimeters, and it has to be something which causes volume reduction. Now, remember, for something to cause volume reduction, it has to have effect against estrogen and it has to have effect against progesterone, something like that. All right. Only then there will be some volume reduction which will occur. And GnRH agonist is something which fulfills that criteria. So, my only worry is that, she has taken this 2-3 times and still the size of the uterus is 9.5 centimeters, which is a bad thing. So usually if you have a size of uterus around 10 centimeters and you give a GnRH agonist, what will happen is at the end of it, you will see this appearance will change slightly on ultrasound. So if somebody is doing it very routinely, you will see that the appearance has changed. Okay. And the size of the adenomyosis will go down by around 10%. It's not going to happen that this 5.5 centimeters becomes 2 centimeters. Okay. Nothing like that will happen. But you will see that there is going to be a slight change as far as the echo texture, okay, of the adenomyoma is concerned. And I think that is a very good sign, because that indicates that there is some hyalinization and liquefaction which has occurred due to apoptosis, okay, due to administration of any of these agents. All right. So the first thing which we've mentioned and which you've already given, okay, letrozole plus depot preparation has no role. Okay, let me just answer that, because letrozole, when you give depot preparation, any which ways the receptors are down regulated. So over a down regulated receptor, letrozole will have virtually no benefit. It will just give other side effects like, softening of the breast and loss of libido and all these things. Dynogest followed by GnRH depot preparation, I don't believe in that at all. Okay, the reason why I don't believe in that is because you can give GnRH depot preparation or you can give letrozole plus Dynogest, but don't give Dynogest plus GnRH depot, because that's not going to work. Now, the fourth option is letrozole plus regesterone. Now, this is a good protocol, but remember one thing, to be attempted only, okay, if the size of the uterus is less than 10 centimeters. Okay, that is something which is very important. You can't really try this in a focal adenomyoma, letrozole plus regesterone. It has to be tried in a case like this where there is a globular adenomyosis on the posterior wall. Okay, letrozole to be administered 2.5 daily in the night, regesterone to be administered 10 mg daily in the morning. Okay, you can even switch. One can be the morning, the other can be the night. There are some patients who are going to complain to you of this loss of libido, tiredness, fatigue, due to this daily letrozole, softness of the breast, sagging of the breast and all these things. For those girls, you can probably take letrozole every alternate day, just in case you want to do this. And you can probably try doing this for around 3 months, not more than 3 months, okay? The immediate next cycle, okay, what you're going to see is you will not see the endometrium, actually. Once the patient comes back to you after 3 cycles of this, you will not see the endometrium. Same thing happens with GnRH agonist 3 months. 11.75 when you give, when the patient comes back to you, there is no endometrium. Okay, it is an empty cavity. So one of the best things to do in modern day practice of fertility is to ensure that when all this is so beautifully down-regulated, no, when the patient comes, you do an office hysteroscopy. Okay, office hysteroscopy is done without anesthesia. See, when you do this office hysteroscopy, you should find one very important thing, that there should be no indentation of the posterior wall of the uterus. Okay, if the indentation of the posterior wall, see what Aarti madam has shown here is a very straight endometrial cavity. Okay, many times in endometriosis, you will have a curved, the endometrial cavity will be distorted, let's say, curved due to adenomyosis. If it is not curved, no, then your outcomes will be fantastic. Okay, just keep this as a very practical tip in your mind. If it is a curved endometrial cavity, that the typical bend one, despite giving these type of therapies, then usually the success rates of implantations are going to be very poor, irrespective of the quality of the blastocyst. Okay, and this is predominantly to do with the poor endometrium which is created inside an adenomyotic uterus. Okay, predominantly due to distortion of the vascular pattern. Nothing much can be done to improvise the vascular pattern. All right. Now, one important thing, I mean, that's your 5th option, is that, role of surgery in this type of situations. See, a dedicated IVF specialist is going to heavily debate this. Okay. There are going to be people who will say, no, I have treated a 25-week uterus also by GnRH depot preparations, and that 25-week uterus patient also conceived. Very good. The patient conceiving and the patient delivering are completely different topics as far as adenomyosis is concerned. Because even if the patient becomes pregnant with such a huge adenomyosis, see 5.5 centimeter adenomyosis, that means the adenomyosis is as big as the size of a normal uterus. Normal uterus 6 centimeters. Okay. So this 5.5 centimeter adenomyosis itself hugely increases the risk of early abortions, especially abortions less than 8 weeks, retrochorionic hemorrhages and all these things. For a lady who has failed previous 2 IVF cycles, okay, with the protocol which you mentioned, okay, but because the endometrium is so good, no madam, I would first like to go with letrozole plus regestrone in this. Now, if letrozole plus regestrone also fails, that 3rd set of blastocyst embryo which you mentioned, that also fails, okay, and that also doesn't cause an implantation. That is when we will try to switch and we will do an adenomyomectomy. Now, the big debate here as far as doing adenomyomectomy is that, when you do an adenomyomectomy, if the cavity is opened, then what will happen? So, frankly, I find it very funny, okay, when people say that in adenomyomectomy, try to not open the cavity. See, if you are doing a good adenomyomectomy, remember 2 things will happen. One, your tube will get delinked. Okay. And second, unfortunately, fortunately, or planned, you will end up opening the cavity. Some part of the cavity will open. The bulk of the uterus will go down drastically. Okay. And your success rate will not increase. Okay, that is the most important take-home point. The bulk of the uterus will go down drastically and your success rate will not increase. Okay, your success rate will in fact never increase if the endomyometrial junction is distorted. That is the most important take-home point for a surgery. This surgery is predominantly to be done in order to relieve the pain of the patient. Okay, or if the size of the uterus is more than 10 centimeters. The reason why I am putting surgery, imagine somebody like me trying to put surgery as number 2 option, is because the size of the uterus mentioned is less than 10 centimeters. Okay. If this uterine length 9.5 ke jagah pe you would have mentioned 11.5 centimeters, no? Then the option number 1 was to do surgery and then do everything else. All right. See, one more very big indication of doing surgery in all these situations. We actually saw the ovaries here. And surprisingly, this lady has absolutely fine ovaries without being adherent to the posterior aspect of the adenomyoma. You know, they are present by the side of this adenomyosis. It's very uncommon for such a big adenomyoma to have completely normal ovaries. You know, usually they will have some endometriotic ovaries badly stuck to the uterus. No, in that type of situation also, as Dr. Aarti has mentioned, if your first or the second attempt fails, in order before you create a fresh set of embryos, ideal to do a corrective surgery. Okay, make the ovaries align to the normal position, remove the adenomyosis, remove the endometriosis, do peritonectomy, put an interseed or any graft you want to put in between this, do a rectal adhesiolysis. Okay, finish it off, allow the patient to be absolutely pain-free. Definitely the hormonal milieu inside the pelvis will improve when adenomyosis is taken out, and you will add to some success rates. Okay. One more important thing I want to mention is that, see, this is a generalized adenomyoma of the posterior wall. If you have a focal adenomyoma which is more than 3 centimeters, it is better to go and operate and then do the embryo transfers. Okay, for focal adenomyosis, they are beautiful, they are removable, they are localized. The pathology of focal adenomyosis is different than pathology of general adenomyosis or globular adenomyosis. What we are trying to discuss here is globular adenomyosis. So focal adenomyosis more than 3 centimeters, better to operate. Okay, better to operate. Really, it will help. There is no role of medical management in focal adenomyomas of more than 3 centimeters. Okay, so keep that in your mind. Right. And my personal tips for endometrial preparation in cases of adenomyosis. See, one thing which we know won't work very nicely is modified natural cycles. One thing which we know won't work very nicely is true natural cycles in adenomyosis. That is because most of the times adenomyosis is associated with endometriotic ovaries. Okay, so whenever it is associated with endometriotic ovaries, that particular thing is not going to work so nicely. Okay, so just keep that in mind, because typically we often end up thinking that it will work. HRT remains the best protocol in all these patients. Okay, absolutely the best protocol in all these patients, and they will do very, very well with this. Okay, as far as HRT is concerned, people often ask estradiol valerate or estradiol hemihydrate. Okay, what is to be used? Now, I mean, see, honestly, there is no such answer to this. I prefer to use estradiol hemihydrate. It is completely the choice of the people what they want to use. Okay, but the crux of endometrial preparation in adenomyosis is really very simple. Okay, if you have a junctional zone which is not distorted, your outcomes are good. If you have a junctional zone which is distorted, usually the implantation will be less than 15% no matter what you do. No matter what you do. Okay. And that, I think, if we want to drive home a point, then I think that is a very, very important point which we need to drive home. As far as, fertility and adenomyosis is concerned, because often, see, these days, what happens in practice is that if we look at ground reality of practice, nobody wants to let a case go. All right. And everybody knows that the outcomes of adenomyosis are poor. Okay. So unnecessarily, if a patient is made to undergo an IVF cycle, okay, 4 IVF transfers with a very poor junctional zone, then the patient changes the doctor and understands that, surrogacy was probably the best option in my situation. That is probably not very good for the long-term reputation of a particular doctor. Okay. So try to focus on that, and hopefully it will help you in at least drawing a chart better. Okay. One more thing I want to actually cover as far as as far as adenomyosis and subfertility is concerned. Okay, and I think many a times people ignore this. Okay, see, most of the times patients who have this adenomyosis will also present to you with low AMH. Okay, fortunately in this situation, madam has mentioned that the AMH is normal. See, it is going to be very rare for a patient with this type of an adenomyoma to produce so many blastocyst embryos. Okay. I mean, when we are talking of 2 FETs, 2 pickups and 3-4 FETs, the patient has formed 4-5 blastocyst embryos. Now, that is something which is incredibly rare to happen in adenomyosis. Okay, incredibly rare. And if it does happen, you are very lucky, because most of these patients with adenomyosis will not give you more than 4 to 5 good quality oocytes. Okay, predominantly due to the pelvic milieu which occurs in adenomyosis. Lot of times people don't realize that if the ovary is stuck behind such a huge posterior adenomyoma, no, you will have to go through the uterus to do your egg pickup. Okay, and that's not a very easy egg pickup. See, lot of times the needle will get stuck inside the adenomyoma. Okay, and people will have to really push it through. People who are doing adenomyosis pickups will understand what I'm trying to say. You'll really have to push it through. You'll have to dig it through the tissue. Okay, and you will have loss of oocytes. So if your oocyte to follicle index will drop down in adenomyosis. So I think this is a very lucky patient to have produced so many embryos. It's a very rare thing, because people often should keep this in mind, about the low AMH, which also presents very heavily as far as adenomyosis is concerned. And then one more thing, of course, I mean, this is not probably covered, or from this case it doesn't seem to be that way. Okay, but these embryo transfers are not very easy, because the cervical canal and endometrium in a typical adenomyosis is distorted, and quite a lot of times you are going to find, okay, quite a lot of times you are going to find that there is a blood on the tip of the outer catheter. That is because your outer catheter goes through that angle. Understanding, the endometrial cavity is bent in most of the situations, and your outer catheter will have a bloody tip in adenomyosis. That is something which you must keep in mind. Okay, it doesn't really affect your success rates, but it really makes you jittery. Okay, and a lot of times people will also experiment with, see, we've discussed all these things, no? Then people also like to experiment with Mirena. That why don't we try letrozole plus Mirena if letrozole plus regestrone is working? Arey boss, putting that Mirena inside, it will start acting after 1 month. Okay, the dose which that Mirena releases is really a microscopic dose. So if you are planning to do an embryo transfer after 1 year, you put Mirena, no problem. It is good. But if you are planning to do an embryo transfer in 2 to 3 months, what Mirena has got no role. Okay, once you remove the Mirena, it will take 1 more month for washout. I mean, it doesn't take 1 more month. It takes maybe 4 to 5 days for the washout to occur, but you will not be able to start an embryo transfer immediately. With letrozole regestrone, what typically happens is the endometrium is so thin, okay, that the day you ask the patient to stop it, next day morning you can give estradiol valerate. There will be no breakthrough bleeding. There will be no withdrawal bleeding. Nothing is going to happen. Just like a GnRH agonist depot, even if there is no withdrawal bleeding, you can start after, let's say, 25 days of administration of the depot. So just keep that point in your head, and hopefully this will take care of almost all the practical things which were there in my head, at least as far as adenomyosis and fertility is concerned. But I'll be happy to answer more questions if Aarti madam has anything to ask.
For very practical insights, Jay. I just have one question. What is your choice of depot GnRH preparation? Is it Goserlin or Leuprolide, Zoladex or Leuprolide? And do you prefer the monthly or the 3 monthly?
No, honestly, madam, I prefer the monthly. Okay, I don't prefer the 3 monthly one, because I am a little unhappy with that erratic effect that 3 monthly has. Sometimes it may work, sometimes it may not really work very nicely. So I like the monthly one, but then I know of people who are very happy with those 3 monthly ones also. But if you ask, my personal opinion is that I like the monthly one.
Okay. Shilpa, do you have any questions? I think we have a few questions from
Dr. Jay, this one. So what is the max or minimum endometrial thickness that you would transfer or start progesterone in adenomyosis? Is there any
usually more than 5.5 is considered to be good enough, madam.
Okay, and have you tried mifepristone in adenomyosis, in global adenomyosis especially?
No, I have not tried, madam.
Okay. So I think with this, Jay, we will end our session today because you've given us quite a few insights on endometrial preparation for such a case. And our next session, we will discuss another challenging case prototype of patients with adenomyosis who conceive naturally, have recurrent pregnancy loss. They want to continue to try naturally. So what are the options? So maybe this is what we'll discuss the next time, Jay. I know you had a hard day, so let's just keep this short and sweet, and lots of good take-home messages. Thank you so much for your insights, and good night, everyone. Anything from your end, Jay?
No. I thought, okay, that this point of embryo transfer is little very important because of that curved endometrial cavity which people have. There is a little difficulty in negotiating many times when you are transferring in an adenomyotic uterus, but that is just something which people should keep in mind as far as adenomyosis is concerned. Okay, the rest of the things I think we covered already.
Right. One question we have here is post-adenomyomectomy. Suppose this uterine length was around 11 centimeters, and that is when you said you would operate. Post-adenomyomectomy, for how long would you wait before again planning an embryo transfer? And would you give a depot post-adenomyomectomy?
So normally we give letrozole plus registrone post-adenomyomectomy, and then we will wait for 2.5 to 3 months.
Okay, so immediately post-adenomyomectomy, 3 months of letrozole.
So, yeah, I mean, there is one important thing as far as post-adenomyomectomy is concerned. It's dependent on what is the type of suturing which you have done. Okay, we try to micromanage it that way. Because see, sometimes you have an adenomyotic uterus, which is very hard. That serosa is very hard. Okay, if you try to strangulate the uterus, no, the sutures will cut through that serosa. Okay, that cases you are supposed to wait a little more. That is because it is almost become like a serosal adenomyosis. Okay, simultaneously, when you have serosal adenomyosis, a part of the serosa will also get distorted. I mean, a part of the serosa will also get compromised. Okay, so in those situations, probably 4 to 5 months waiting is considered to be good. But if you have this focal adenomyosis or adenomyosis not extending up to the serosa, where serosa can be flapped over each other. See, serosa can only be flapped if the serosa is pliable. You can't really have a stony hard serosa which you can overlap. Understanding? So if you are able to flap a serosa, then maybe you can initiate embryo transfer protocols within 2.5 to 3 months. But remember, post that, your cavity is going to become more tubular. You are going to have a much more tubular cavity. That is something which is important to understand. But otherwise, we can discuss this. The whole thing, okay?
Do you do a rehysteroscopy, Jay, if you did an adenomyomectomy?
No, I don't do it. I don't do it.
Okay.
What your points are, like, only if you operate and if you do the embryo transfers, then you will know all these finer points. Or
Yeah.
as a uniform this thing where everybody should mention, or the endoscopic surgeon should mention about whether it was involving the like subendometrial space or even the serosal space, and then probably we should I don't know, I mean, I think it will be tough for everyone to have this kind of inputs from the endoscopic surgeons to take it forward.
Yeah, but I think if you have to really micromanage, then that is the best way to take it forward, madam.
Yeah.
One last question, Jay. What is your experience of intrauterine adhesions post-adenomyomectomy?
See, intrauterine adhesions will occur if you end up suturing the endometrial cavity or a large part of the endometrium cavity is distorted. Okay. And which is why I am saying, you will end up cutting the cavity through and through in most of the times of adenomyomectomy, and you will end up removing a large part of the cavity provided the endometrial junction is not intact. Okay. In that situations, as I said, your outcomes are very poor any which ways.
Yeah. Right. Okay. So I think we can end today's session, Jay. Thank you. Thank you, Shilpa. Thank you, everyone, for logging in so late.
Thank you, guys.
Yes. Any remaining questions may be